Hello everyone, I'm Dr. Lahari here from the Department of Oral Medicine and Radiology, and the topic for discussion today is miscellaneous disorders of the oral mucosa. The term miscellaneous means a variety of conditions which probably cannot be grouped under one category, and that's the reason why we're having it in a group in this chapter. The learning outcomes would be explain the rationale of unclassified lesions of the oral cavity, describe the clinico-pathological concept of geographic tongue and orofacial granulomatosis, identify clinically common entities like fordyces granules, sublingual varices, and lingual tonsil. And finally, identify and describe endogenous and exogenous pigmented lesions of the oral mucosa. I will be first talking about the endogenous and exogenous pigmented lesions of the oral mucosa in this topic. And the slide that you can see here is a palette of so many or a combination of so many pigments. You actually don't see so many colors in the oral mucosa, but nevertheless, I thought it was very representative of the topic, and that's why I've chosen to place it here.
So if you were to look at oral pigments, so by now you would have understood that the term pigment is used for change in color seen on the tissue, soft tissue or the mucosa, whereas staining is the term used for a color change on the hard tissue structure. So here the oral pigmentation has actually been classified as pathologic and physiologic, and the pathologic one is further of endogenous origin and exogenous origin. That means endogenous, that means arising from within the body, like for example hemoglobin, hemosiderin or melanin pigments. So this is just a picture to show you how the melanocyte looks like, and this arrow mark is pointing out towards the melanin pigment that it has released around it, leading to the brownish hue that we see on the mucosa. Oral pigments are classified as a focal melanocytic pigmentation, multifocal or diffuse pigmentation, melanosis associated with systemic or genetic diseases, idiopathic pigmentation, and hemoglobin and iron associated pigmentation. So the first three are most commonly associated with melanin as a pigment. Focal melanocytic pigmentations. Examples under this would be freckles or ephylis, oral or labial melanocytic macule, oral melanoacanthoma, melanocytic nevus, and malignant melanoma. Let's look at each one of these in detail. Freckles are what we see on persons generally can be fair-skinned individuals or generally Caucasian or even people of mixed origin, and are mole-like but have a lot of and they're hard to get rid of. So those what our freckles are. So again, these are oral labial or melanocytic macules. This is seen on the vermilion border of the lip. It's less than 1 cm inside, and there is increased melanin pigment without increase in number of melanocytes. So essentially it's a form of melanocytic hyperplasia. So very commonly seen on the lower lip and in junction of the vermilion border and the labial mucosa, that is this area. And the differential diagnosis would be melanocytic nevus, malignant melanoma, amalgam tattoo, which is again difficult to find on the lower labial mucosa, and focal ecchymosis. On the other hand, an oral melanoacanthoma is more of a reactive lesion of the mucosa due to trauma or constant irritation. In this case, there is proliferation of benign dendritic melanocytes. This is more commonly seen in black-skinned persons. So here you're seeing an area of dark pigmentation seen in the buccal mucosa of this individual here. Next is the melanocytic nevus. The term nevus generally gives you an understanding that it's probably a mole or present since birth. These could be acquired or congenital. And generally nevi are due to melanocytic growth and proliferation. Increased nevus susceptibility is seen in inherited diseases like Turner's syndrome and Noonan syndrome, right? So here you can see a child with the nevus on the forehead and an intraoral nevus as well. In case of oral lesions, generally a biopsy is needed to rule out malignant melanoma, especially if your nevus is of this size, about 1 centimeter in size. If on biopsy they turn out to be benign, then a complete laser excision or a surgical removal is can be recommended. On the other hand, a malignant melanoma, as the name itself suggests, is a malignant lesion. It is the least common but most fatal of all skin cancers. The risk factors for cutaneous, the ones which arise in the skin, are acute sun exposure, immune suppression, family history, and the presence of multiple cutaneous nevi itself. The clinical characteristics of cutaneous melanomas are described using the ABCDE criteria, and these have been given existing since quite a long time, but they have been a very consistent method of actually describing the clinical characteristics. First of all, whenever a melanin pigmented area is observed, it's important to see a presence of asymmetry, whether the lesions of the border are irregular, is there difference in color variation, and also if the diameter is greater than 6 cm and if the surface is elevated, then you're looking at a suspicious lesion. In case of mucosa, the melanomas are quite rare. Just less than 1% of them occur in the sinonasal or oral cavity, and also there are no known risk factors or etiology. So inside the oral cavity, the clinical features would be more like macular or plaque-like mass, which is well circumscribed or irregular, and brown to black pigmented. And there are very few cases out of this 1% where there is no pigmentation at all, and this phenomenon is called as amelanosis, and this has a very poor prognosis. 5-year survival rate is only 15 to 40%. I mean, this prognosis we're talking in terms of mucosal melanomas. So the diagnosis could be that of a primary melanoma or a metastatic oral melanoma. That means a melanoma can arise primarily as a first lesion seen in the oral cavity itself, or could be a metastatic lesion where the primary is elsewhere and you could see metastasis into the oral cavity. Management is generally local excision followed by radiotherapy, but sadly these patients have a very poor survival rate. This is example which I have taken from the internet, a large malignant melanoma which is having seen that you can see that there is a raised area which is not uniform, irregular borders, and is also showing you color variation. Some areas are darker pigmented, some are lighter pigmented, and definitely greater than 6 cm in size, 6 mm in size. So this gives us an idea of how an oral malignant melanoma would look like, or a mucosal melanoma would look like. Moving on, let's look at some multifocal diffuse pigmentation. So what we saw previously were focal pigmentations, that means restricted to one particular area. Multifocal means can be more diffuse, and multiple areas can be pigmented. These could be physiologic, drug induced, smoker's melanosis, post-inflammatory hypopigmentation, or melasma or chloasma. Let us look at what these are. Physiologic pigmentation happens in dark or tan skinned individuals, where the mucosa inside or the gingiva in the oral cavity also takes on the pigment of the skin color. So darker skinned individuals tend to have darker pigmented gingiva. So hence there is no treatment required, and it is just considered physiologic. So this sort of pigmentation can be seen in the other areas of the oral cavity as well, including the dorsum of the tongue, floor of the mouth, and even the buccal mucosa. Drug-induced melanosis can be caused by drugs itself or their metabolites, which stimulate melanogenesis or get retained within the melanocytes. So common examples for these are antimalarials, phenothiazine, oral contraceptives, and even cytotoxic drugs. That means cancer chemotherapy can induce heavy pigmentation because the melanin that is either the drug gets retained in the melanocytes or it stimulates melanogenesis. Smoker's melanosis. Here we have a picture of an interesting individual with the habit of smoking. or at least had the habit of smoking. Tobacco smoke products, what happens is the heat stimulates melanin synthesis and hence induces this mild pigmentation which we are seeing on the entire gingiva, especially even the lips and the tongue and other parts of the oral mucosa. These are not pre-malignant and have essentially smoker's melanosis doesn't mean that the patient is having a potentially malignant disorder. It is again not associated with smokeless tobaccos. Smokeless tobacco, since it doesn't generate heat, does not produce this sort of pigmentation. The diffuse melanocytic pigmentation is also seen in OSMF, which could happen because of the process of the disease itself. Alcoholic melanosis can happen in the posterior part of the oral cavity, where alcohol induces the the process of melanin production. So what happens in smokeless tobacco or chewing tobacco is that the residue that is left over the mucosa gives a reddish hue, and it can actually be scraped off or gets embedded into the superficial layers, and hence it's not generally a pigment, but it's more of a stain that just gets retained because of the extensive pigment produced by the products in the areca nut. So this is just to compare drug-induced melanosis with smoker's melanosis. Sometimes it can be very difficult to tell the difference, but the pictures that we see here show that probably minocycline-induced melanosis is seen more in the lower part of the attached gingiva and is more uniform and grayish, whereas the one with smoker's melanosis is a little more diffuse and probably existing all over the attached gingiva. The next term is post-inflammatory or inflammatory hyperpigmentation. This can happen as a result of pigmentation after an inflammatory episode. For example, the pigmentation that is seen after acne have healed, or especially in case of oral lichen planus pigmentosis. The lichen planus heals with pigmentation, and this is called as lichen planus pigmentosis, but that's again a process of healing, and because it's an inflammatory disease, when it heals it leaves back pigmented areas. The term melasma or chloasma is used, is also called as a mask of pregnancy. Is generally there is facial hyperpigmentation which is associated with the pregnancy or ingestion of contraceptive hormones. It is we can see that the patient's face here has a pigmentation, and that is why it's called as a mask of pregnancy, and generally subsides after after postpartum. Classification of melanosis associated with systemic or genetic diseases is Addison's disease, Cushing's syndrome, hyperthyroidism, primary biliary cirrhosis, vitamin B12 deficiency, Pugh-Jaeger's syndrome, cafe au lait pigmentation, and HIV or AIDS associated. So it's not limited to these diseases, but these are some of the most prominent ones where there is melanosis associated with a systemic or a genetic disease. This is an example of a girl with Addison's disease where there is adrenal insufficiency and hypoadrenocorticism. You're seeing that there is pigmentation on the feet as well as heavy pigmentation of the gingiva and the lips as well. Cushing's syndrome, generally the patient has moon faces and there is diffuse mucocutaneous pigmentation. What happens actually is primary pituitary neoplasm increasing the ACTH hormone, and there is or there could be a primary adrenal pathology causing hyperadrenocorticism. In Pugh-Jaeger's syndrome, you see that this is an autosomal dominant disease. There are intestinal polyposis and also cancer susceptibility, and then multiple small macules less than 0.5 cm are seen on the lips, perioral skin, hands and feet. So this is the very typical feature of Pugh-Jaeger's, where you see multiple tiny macules all over the lips and other areas of the skin. Cafe au lait means coffee with milk. Generally tan or brown irregular macules that are seen on the skin, seen in neurofibromatosis, McEwen-Albright syndrome, Noonan syndrome, Leopard syndrome. And when you're seeing multiple of these cafe au lait pigments, it is important that you suspect some genetic disorder and the patient must be subject to the necessary investigations. Moving on, there is something called as idiopathic pigmentation also, which is there in the diagnosis, in the classification, and under this we have one peculiar disease called as a Logier Hunziker pigmentation. Quite rare, but this is an acquired idiopathic macular hyperpigmentation of oral mucosa, also seen in esophagus and genital, conjunctival mucosa, as well as nails. It's again having a genetic predisposition with no systemic abnormalities except pigmentation we can see on the patient's lips here, fingers, as well as pigment on the nails. The treatment of mucocutaneous melanosis could be primarily dermatologic treatment, which could be aesthetic, concerning aesthetics for the patients. First of all, withdrawal of the offending substance, like if, for example, smoking, alcohol, or if there is any systemic involvement, then by treating the systemic disorder, the pigmentation could subside. Otherwise, for lesions which are not because of any of the above causes, for example, nevi or melanoacanthomas, a laser therapy using carbon dioxide or Nd:YAG lasers can be done. Cryotherapy is also an option, and topical bleaching creams can be used. For example, the one happening because of post-inflammatory pigmentation seen in acne. These generally contain azelaic acid or hydroquinone, retinoic acid, and some amount of steroid in it. Also, phototherapy has been tried as a managed treatment modality for mucocutaneous melanosis. Now, we've talked about pigmentation, let's talk about depigmentation as well. Generally, the disease that arises because of depigmentation is called as vitiligo. It's common acquired autoimmune disease causing hypomelanosis and destruction of melanocytes happen in that. It could be genetic or environmental. Lips and perioral skin is generally affected in 20% of the cases. The treatment generally could be topical corticosteroids, photochemotherapy, and autologous epithelial grafts can also be done to deal with the pigment. Vitiligo can also be seen as localized and restricted to few areas. For example, it starts off as a small depigmented area here, in this case seen on the lower lip, or as a symmetrical distribution in this patient, in this person right here. Moving on, hemoglobin and iron associated pigmentations. Now the examples for this would be ecchymosis, purpura, petechiae, and hemochromatosis. Ecchymosis can occur because of extravasation into the submucosa, leading to erythematous or more of a purplish red appearance of the mucosa. It is generally rare in the oral cavity, but a blunt force trauma can lead to this sort of appearance. For example, here you see the floor of the mouth. There would have been a blunt injury to the jaw, leading to bleeding under the submucosa, leading to a pigmentation like this. Similarly, seen on the skin of this patient here, you can see a swelling on the angle of the mandible region, suggesting that probably there would have been trauma to that area. On the other hand, purpura and petechiae are also happening because of the same phenomenon, trauma and extravasation of underlying blood vessels. Ecchymosis could be a larger vessel which is ruptured, whereas purpura and petechiae are smaller in size and could be due to rupture of capillaries. In the oral cavity, trauma induced because of even cough inducing trauma to the area can lead to multiple red spots like this, leading to appearance of petechiae. Even viral infections can induce the appearance of petechiae, and bleeding disorders. Bleeding disorders especially seen in patients who have platelet insufficiency. Hemochromatosis, on the other hand, is a chronic progressive disease in which excessive iron deposition happens in the form of hemosiderin. So this is could be idiopathic or neonatal, or can happen due to blood transfusion, and can also be seen as a heritable disorder. Or in the oral cavity, diffuse brown gray pigmentation is seen, and a labial biopsy can give the appearance of hemosiderin deposition, which is generally stains golden brown with the Persian blue stain for iron. So here you can see that there are deposits of areas of iron deposition, and hence this is the histology picture of hemochromatosis, which is the mucosa has been stained, or the sample has been stained with Persian blue. Moving on to the last part of this lecture is staining of teeth. As I told you, the term staining is generally used for heart tissue or the stains that are seen on teeth, and these could be again intrinsic or extrinsic in nature. Intrinsic is because it is arising from within the body itself, and extrinsic is when an external source leads to staining of teeth. Example of intrinsic stains would be, for example, tetracycline stains. You can see grayish brown pigmentation, or staining of the teeth caused by tetracycline consumption in tetracycline consumption which is passed on from the mother to the fetus or during early childhood. And tobacco stains, on the other hand, are extrinsic stains and can be removed with scaling, whereas intrinsic stains cannot be removed with scaling. So the treatment plan for extrinsic and intrinsic staining would be slightly different from each other, and will be dealt with in detail, giving more importance to aesthetics in conservative dentistry and endodontics. So I would like to explain here that the term staining is different from pigmentation. We use the word pigmentation when we're referring to change in color or a colored lesion seen in the mucosa or on the skin, and the term staining is generally used when we're talking about staining of hard tissue structure like the teeth. Now for one particular example, I did use the word staining of the mucosa, which is when you're having an external source like betel nut or areca nut constantly consumed, can actually stain instead of actually pigmenting it. It stains and forms a crusting on the mucosa in patients who are chronic betel nut chewers. So that again, the mucosa gets pigmented superficially, it gets stained superficially, and it can actually be scraped off. So that is all about this chapter. It's a pretty easy chapter, easy to understand. I want you to go back and read the textbook for more details. I have covered the most important examples here in this chapter. For the rest of the details, I would want you to read the textbook. From importance or exam point of view, you would generally expect short answers or MCQs from this chapter.
Now that we've had a look at the pigmented lesions of the oral mucosa and a little bit about staining of teeth, we will cover the rest of the 3 learning outcomes in the next part of miscellaneous disorders of the oral cavity. Thank you.